To set the stage for today, you might remember that in March, we heard from Dr. Philip Landrigan, class of 1959, about ocean pollution and its impact on human life. Incidentally, Dr. Landrigan began his medical career as a pediatrician, so the discussion about using science to care for and to save lives continues with our discussion today. Dr. Andemariam will walk us through what sickle cell disease is and how gene therapy is being used in the fight against this disorder that affects millions of people worldwide. You should also know that World Sickle Cell Day was established by the United Nations General Assembly in 2008, was recognized for the first time on June 19th, 2009, and has been celebrated annually ever since, and certainly not by accident that it falls on Juneteenth Day. Check your Google on that. The International Awareness Day is observed with the goal to increase public awareness about sickle cell disease and address and identify the challenges experienced by patients, their families, and their caregivers. So, before Dr. Andemariam drops a little science on us, I'd like to introduce Peter Kelly, president of the Boston Latin School Association, who will provide the warm introduction of Dr. Andemariam. Peter, the screen is yours.
Thank you, Nicole. Good morning, everyone, or good afternoon, depending upon where you're calling in from. It's a pleasure for me to welcome today's speaker, Dr. Biree Andemariam, from the class of 1992. There was early foretelling of Dr. Andemariam's success when she graduated near the top of her class, gained admission at Princeton University, and earned one of the nation's top honors for high school students when she was named a scholar of the Jackie Robinson Foundation. Through the years, she's remained a loyal alumna of Alma Mater, a valued member of a class noted for its esprit de corps, and a founding member of the BLSA's Black Alumni Advisory Committee. Graduating with research honors from Tufts University School of Medicine, Dr. Andemariam's residency in hematology and oncology took her to Cornell and the New York Presbyterian Hospital. Today, she's an associate professor of medicine at the University of Connecticut, her professional home since 2007. She's the founding director of the New England Sickle Cell Institute and the immediate past chief medical officer of the Sickle Cell Disease Association of America. As a clinician and as a researcher, her work has saved and improved the lives of thousands suffering from a disease that has been little understood, underfunded, and devastating to those afflicted. As a mentor, educator, and worldwide advocate of growing renown, Dr. Andemariam is building a legacy that is literally changing our world. We're proud to call her a member of the BLS family and to welcome her in sharing her insights with us this morning. Welcome, Dr. Andemariam.
Thank you so much, Peter, for that fantastic introduction. It brings back a lot of memories, and it's truly an honor to be here today representing the great class of 1992. Thank you also to Nicole for all of that you've done in developing this seminar series and for putting my name in the running to present to you all today. Peter, thank you for giving some background on sort of the etiology of my passion in sickle cell disease. We are going to focus on gene therapy, particularly in the Q&A session, but in thinking about presenting sickle cell disease to a general audience, I thought it would be important to give you a mini lecture on what sickle cell disease is, where we've been, and where we're headed in this exciting time of potentially curative gene therapy. So I'm going to share my screen now and give you guys a mini lecture. So I hope that everyone can see my screen. And I'm happy to let you all know that in the intervening time between being invited to give this presentation and today, I've actually been promoted to full professor of medicine. So I'm very excited about that. So the title of my talk is Sickle Cell Disease in the 21st Century, Healing Old Wounds with New Hope. So my objectives today are fourfold. I hope by the end of the hour, you'll appreciate the history of sickle cell disease in our country, understand the role of scientific discovery as well as grassroots advocacy efforts in advancing clinical care of those affected. I hope you'll be able to recognize the measures being taken to align the pace of fantastic therapeutic advances with the needed improvements in access to basic care. And I also hope that you'll gain an understanding of gene therapy's role in combating this disease. So I want to start here. So imagine this person's typical story. So this is Carol. Today she's feeling great. She's 24 years old. She's working part-time as she completes her graduate degree. When she went home today, she felt terrific. She told her classmates and her work colleagues that she'd see them tomorrow as usual. She lives alone. She and her fiance are saving up for a wedding next year, and they hope to have children before they turn 30. But the next day, Carol woke up at 3 o'clock in the morning with severe pain in her back and her legs. She used ibuprofen and heating pads to try to control the pain, but the pain intensified. She took one of the morphine pills that she kept on hand, but by 2 o'clock in the afternoon, she was still in extreme bodily pain. She tried to manage at home alone, but then she began to have chills and she developed a fever of 102. So she called her fiance at about 5 p.m. and he took her to the local emergency department for help. She knew she was having another sickle cell crisis and that the fever could be a serious infection. And although it was a struggle, she put on makeup and business casual clothes before leaving the house. Carol was really stressed out because she had a major exam the next day and a big project due at work. The doctors ran some tests and told her that she had pneumonia and she needed to be hospitalized. She began to worry about school and worry about work. Whenever this happens to her, she always feels like her employer and her professors don't believe her because she, quote, looked fine yesterday. She was transported from the emergency department up to the hospital floor. It took 5 hours for anyone to give her any treatment for her pain. And then she heard the physicians in the hallway talking about her and say, quote, she doesn't really look in pain. And she thought to herself, here we go again. In a week after being discharged from the hospital, Carol follows up with her primary care physician and he looks her in the eye and he says, I don't have any medications that can fully prevent all the complications you experience. There's no universally available cure for what you have. Did you know that pregnancy is risky? Do you even know if your fiance is a carrier for this disease that you have? And you know what, Carol, maybe working and going to school is just too much. So what is this disease that Carol has? Sickle cell disease. Sickle cell disease is actually the most common inherited blood disorder globally. There are millions affected worldwide, and 300,000 babies are born every year with sickle cell disease across the globe. Its geographic distribution parallels the malaria belt and the US slave trade. The reason it parallels the malarial belt is that having sickle cell trait or being a carrier only for sickle cell disease confers relative protection from serious malarial infection. So where malaria is endemic, sickle cell disease is also prominent. In the US, it's estimated that 100,000 Americans live with sickle cell disease. It's heralded by early mortality with a median survival of about 40 years. But for those of us who take care of individuals with sickle cell disease, we often see them die in their 20s and 30s. There's a disparate life expectancy that varies between whether or not the individual lives in a resource-rich area of the world, like the United States and Western Europe, or a resource-poor area. In fact, 50 to almost 80%, depending on the country, of children born with sickle cell disease in Africa die before the age of 5. This is in contrast to the more than 90% survival to adulthood in children born in the United States with sickle cell disease. If you look at the global prevalence of sickle cell disease and look at the 2010 statistics, you see that there are about 300,000 babies born globally every year with sickle cell, and nearly 80% of them are in sub-Saharan Africa. In fact, 57% of the babies born with sickle cell disease are born in 3 countries: Nigeria, India, and the Democratic Republic of the Congo. If you look at projections in 2050, there's going to be a substantial increase in the number of babies born around the globe, more than 400,000 every year. And the burden of disease in sub-Saharan Africa will grow to 85%. What about the impact of economic migration? So many of you may be aware that in probably the past decade or so, there have been individuals who have left sub-Saharan Africa to migrate primarily to Europe for better economic opportunity. And many of those individuals carry either sickle cell trait, which can be passed to other generations to develop into someone with sickle cell disease. In fact, some of the passengers across the treacherous voyage across the Mediterranean, as depicted in this picture, have sickle cell disease. And if you look at countries, for example, like Germany, they have had an exponential growth in the number of individuals living with sickle cell disease in their country because of this economic migration. In the US, I think we'll all agree we live in a resource-rich nation, especially when it comes to healthcare. We have a very small fraction of the world's burden of sickle cell disease, about 2,000 births per year. But I want to spend some time in this lecture explaining to you the impact of limited access to care for those living with sickle cell disease, particularly adults. And on the right side, you see the geographic distribution of individuals living with sickle cell disease across the 50 states, showing the majority of the sickle cell disease burden is on the East and West Coast and the Midwest, as well as the South. So let's talk about limited access to adult care. Are we really talking about the United States? Absolutely we are when we're talking about sickle cell disease. So what are some of the factors? Well, geographic, if you don't live close to a center of excellence, or if you're in the middle of America and living with sickle cell disease, you may not have access to expert care. There are socioeconomic impacts associated with having sickle cell disease. When you have a chronic debilitating condition, it's often hard to maintain optimal insurance that gains you access to specialty physicians. And if you're living below the poverty line because of a chronic illness and an inability to maintain employment, you have trouble with transportation at times and competing psychosocial stressors that can be financial, employment related, or school related. There's also a problem with access to providers who have knowledge about sickle cell disease or feel comfortable. And there's a degree of mistrust between providers and patients that I'll explore with you later in this lecture. The fact that opioids are the mainstay of therapy for severe pain in sickle cell disease is also a factor limiting access to care. And the fact that a chronic disease without a lot of therapeutic options creates this dynamic in medicine where the physician often feels that these types of patients are time heavy, meaning time intensive, but that they don't have a lot of therapies to offer. And in some ways, that's not what a lot of doctors are looking for when they go into medicine. They want to be able to offer things to the patients and often focus their area of interest in medicine towards diseases where they can offer a lot of treatments. So let's talk about transition briefly. What's transition? So transitioning in medicine is the process of going from pediatric care to adult care. And in hereditary conditions like sickle cell disease, this happens as soon as a child reaches adulthood. They go from the pediatric experts' care to the adult experts' care. But the issue with sickle cell disease is that although more than 90% of children are expected to live beyond the age of 21 in the United States, it's now been revealed that it's this transition stage where they have the highest rates of mortality. And if you look at the Dallas newborn sickle cell disease cohort study that was published over 10 years ago now, they identified that there was a trend over time towards an older age of mortality. And that's what those curves at the right show. And that the 7 newest deaths all occurred after the patient was transferred to adult care, with a median time from transition to death of 1.2 years. So let's just take a look at sort of how sickle cell disease develops. So first of all, it's inherited. It's not something that you catch. And if you look at the diagram there, you see a typical example of 2 unaffected parents who have sickle cell trait, which doesn't cause any symptoms. And oftentimes people don't know they have sickle cell trait. And if they have children together, you'll see that there's a 1 in 4 chance with every pregnancy that pregnancy will result in a child with sickle cell disease. Now, sickle cell trait is actually very common. It's 1 in 100 Latinos carry sickle cell trait. 1 in 12 African Americans carry sickle cell trait. 1 in 10 Jamaicans. 1 in 4 Nigerians. And because I live in Connecticut, and I often try to advocate for more resources for individuals with sickle cell disease in Connecticut, I always like to show this newborn screening statistic, which shows that 1 out of 60 Connecticut births results in a baby who has sickle cell trait. And this is all babies independent of race or ethnicity. So what causes sickle cell disease? Well, it's a hemoglobin disorder. So what is hemoglobin, you might ask? Well, if you take a red blood cell and you open it up, it's essentially just a big bag of hemoglobin. Okay, so the major content of red blood cells is hemoglobin. Hemoglobin's job is to bind to oxygen and then deliver it to all the body's organs so that they can carry out their necessary function. Hemoglobin comes in 2 main forms, and this is important when we talk about therapy later. So the first form is the fetal form. The fetal form is what the fetus or the growing baby in the mother's womb expresses. Okay, so fetal. But as soon as the baby is born, it stops making the fetal form of hemoglobin and starts making the adult form. And it's the adult form that's affected by sickle cell disease. So it's really just what I like to call an inherited misspelling. So this is a depiction of DNA and the double helix that some of us learned about. And if you look at the top, that's a correctly spelled hemoglobin DNA, right? But if you look at the bottom, there's one little change, one little misspelling in the DNA that gives rise to something that looks like hemoglobin, but it isn't really hemoglobin if you look. There's been a substitution of the O in hemoglobin for an A. So it's a simple misspelling in the DNA that's inherited. Red blood cells with sickle hemoglobin inside of them have a very different shape from unaffected red blood cells. So you'll see in this scanning electron microscope a picture of red blood cells on the left. Those are unaffected red cells. They're plump, they look like donuts. They're easily deformable. They can get through circulation and do their job delivering oxygen very well. But in someone who's inherited sickle hemoglobin, their red blood cells are distorted in shape and look like crescent moons or sickles. So red blood cells with sickle hemoglobin are really fragile. They break open in a process called hemolysis. And this makes the individual with sickle cell disease anemic. They just don't have as many red blood cells circulating as the average person. When the red blood cells break open and hemolyze, they release a yellow pigment that can cause a yellowing of the eyes and sometimes the skin. The cells don't get through circulation very well because they're rigid and misshapen, and they can get stuck in the spleen. And the spleen is a really important organ that helps us to fight off infection. But over time, as you can see in that picture, because of repeated blockages to blood flow in the spleen gets smaller and smaller and smaller to the point where it's not functional. And this makes people with sickle cell disease highly susceptible to infection. The sickled red blood cells can get stuck in virtually any blood vessel in the body, and this leads over time to chronic organ damage, which includes the kidneys, the lungs, the heart, the joints, you name it. What are the clinical consequences of having sickle cell disease? I like to divide it into 2 categories, one that causes morbidity or sickness, and the ones that cause mortality or death. And the major causes of morbidity are due to vessel blockage. And this leads to pain, as well as, particularly in children, stroke. In fact, until very recently, the #1 cause of stroke in childhood was sickle cell disease. The clinical consequences that lead to death are infection, as we discussed, as well as sudden death. What are the treatment options? We'll go into more detail later about gene therapy, but we haven't had a lot of treatment options. So what we do is we try to prevent infection. So every child that's born with sickle cell disease is put on penicillin prophylaxis. They take penicillin twice a day, every day until the age of 5. And this was shown to increase survival in childhood by simple penicillin prophylaxis. We also screen children between the ages of 2 and 16 every year for risk of stroke. And if they're found on an ultrasound, and like you see in that top picture, to have a high risk of stroke, then they're put on blood transfusions every month for life to try to dilute their blood and give them healthy, normal donated blood. Painkillers like morphine are the mainstay of therapy to treat the pain episodes. And even though sickle cell disease was first discovered, and we'll get to this, in 1910, it wasn't until 1998 that we had the first FDA-approved drug for sickle cell disease. It's called hydroxyurea. And then nearly 20 years went by until 2017 and then 2019, when we have now 3 additional FDA-approved drugs. So this is an exciting time for sickle cell disease. But if you talk to most patients with sickle cell disease, and I spend a lot of time doing that, they'll tell you that there's a lot of hope and prayer involved with living with sickle cell disease. What about a cure? Well, bone marrow transplantation is a known cure, and it was established in 1983 when a little girl who had sickle cell disease developed leukemia. And in order to treat her leukemia, she underwent a bone marrow transplant and subsequently was also cured of her sickle cell disease because the sickled cells originate in the bone marrow. But Black individuals are 1/4 as likely to have a full sibling that matches their bone marrow as whites in this country. Additionally, it's very difficult to find a bone marrow transplant specialist who's willing to transplant sickle cell patients because of the risks. And it's still considered experimental in adults. So even though we have a cure, it's not a universally accessible cure, and it has substantial risk, including risk of death. Let's talk a little bit about sickle cell pain. I've been sort of dancing around this topic, but it really is the hallmark of the disease. The pain is severe, it's intermittent, it comes out of nowhere, it's totally unexpected, and the triggers are not completely understood. There's no treatment for the sickle cell pain crisis once it starts. We don't know enough about the science of how these pain episodes occur that allow us to really impact them in any direct way. So what we do is we bring these patients into the hospital and we give them high doses of opiate-based medications like morphine to try to mask the pain until the underlying process subsides, and that usually takes several days. But the fact that the mainstay of treatment is quote unquote narcotic based has created additional unwarranted stigma in this disease that I want to explore a little bit further. So when we go to medical school, or if you go to nursing school, for example, what we're taught is that if somebody tells you that they have pain, they need to look like they're in pain. They need to be crying. They need to look despondent. If they're a child, they need to be having a tantrum. And the problem is in sickle cell disease, since this is a lifelong condition, oftentimes when patients are having a severe sickle cell pain episode, they look fine because they're used to being in that degree of pain. So they may come into the emergency department, they may be laughing, they may be smiling, they may be watching something on their phone or talking to someone on the telephone to try to distract them from the pain. They may be even eating a meal. But this usually comes back to, to hurt them, because the providers who are unfamiliar with sickle cell disease pain often think that they're just there to get morphine and that they're not really there for help and for treatment of severe pain. And this is what I call the painful misperceptions associated with sickle cell disease. This is a picture by a famous artist named Hertz Nazaire, who lives with sickle cell disease, and he calls this 10 redefined. And the reason he calls it that is because when we ask patients how much pain they're in, we use a scale of 0 to 10, 10 being the worst pain you've ever had in your life. And if you ask somebody living with sickle cell disease to describe their pain, they'll say a scale of 10 doesn't even begin to define it. But the problem is, as you see the scales of injustice at the bottom there, for the less than 1% of individuals that might be showing up in the emergency department pretending to have sickle cell disease or pretending to be in pain just to get opioids, why do we oftentimes in medicine, hurt those, the greater than 99% who are there legitimately that just need our help? Why do we do that? The other issue in sickle cell disease is a great deal of stigma that we'll talk about a little bit later in this lecture, but the stigma is imposed on individuals with sickle cell disease by the healthcare system, particularly healthcare providers, particularly doctors and nurses, pharmacists who make it difficult for these patients to fill legitimate opioid pain prescriptions when they go to their local pharmacy to get pills to manage their pain at home. Sometimes it's from family who don't completely understand their loved one's sickle cell disease. And over time, the stigma can actually be self-imposed. So adults with sickle cell disease in our country, it's been demonstrated in many research publications. They receive less preventative care. They have more complications. They have more days spent in the emergency department as well as hospitalized than children. They also account for 75% of the $2.4 billion per year spent in this country on acute sickle cell care, acute being hospitalizations and ED visits. That $2.4 billion doesn't even cover routine care. So it's an expensive condition, largely because of a lack of good access to care. So what about this, what I call a adult sickle cell cycle of drug-seeking behavior? How does that perception actually develop? Well, as you look at this diagram, so an adult with sickle cell disease has a pain crisis. They're at home. They've exhausted all measures to try to manage that pain at home. They don't have a doctor. So what do? They go to their local emergency department. And two things can happen. Either they get hospitalized or they're discharged and they're sent back home. But because they don't have a regular doctor, they're not put on any medication to try to prevent these pain episodes from occurring again. So the cycle continues. The pain crisis emerges again, and they end up in the ED and possibly hospitalized. So this sets up a sort of a situation where this is feeding into this perception of distrust about whether or not the patient actually has pain. It enhances stigma. It's rooted in bias. And it promotes increased morbidity and mortality unnecessarily in this population. Let's talk a little bit about the Pisces study. So the Pisces study was published in 2008 to try to understand the pain experienced by adults living with sickle cell disease. And what they did is they took 232 adults with sickle cell disease and told them to keep a pain diary every day for 6 months. At the end of this project, they had 31,000 daily diaries describing the pain of these 200 plus patients. And what they saw is that pain was actually reported on a majority, 56% of the daily diaries. If you look a little bit further as to each of the daily diaries that were submitted, you'll see that the pain experienced by sickle cell disease that we see as healthcare professionals is just the tip of the iceberg. So starting from the bottom, if you look at all those 36,000 pain days, 44% of days were no pain. If you go up to the orange box, about 39% of those days were spent in pain, but they weren't calling it a crisis, and they weren't utilizing any healthcare. If you look a little bit higher, 13% of the days were in crisis, pain crisis. They were experiencing pain, but they weren't utilizing any healthcare. They were trying to manage at home. And it's only 3.5% of all pain days, which we actually see as healthcare providers, where a patient actually has maximized all options at home and utilizes an emergency department or hospital. So there are pervasive inequities in sickle cell disease that are embedded in provider availability, until recently, pharmaceutical interest in developing new drugs, and NIH research funding. And this is in sharp contrast to another inherited blood disorder, which is far less common, which is hemophilia, which has a lot of provider availability, a lot of drug therapy, and a lot of research funding. So again, transition to adult care, going from pediatrics to the adult world, is a major gap in clinical progress. So where are all the adult hematologists like me? Believe it or not, we are a dying breed, and that the majority of us do a combined fellowship in hematology and oncology. Oncology is the study of cancer. And most people who do a hematology oncology fellowship do it because they really want to treat individuals living with cancer. And very few choose that specialty to care for adults with sickle cell disease. So in many ways, the progress that we've seen in pediatric care has been without long-term benefit in adults. So let's go through this a little bit. So this is what I call the disease-independent root causes of adult sickle cell disease mortality. So if you have at the bottom right there, as I circled, limited physician access, what happens? You get suboptimal care. It doesn't matter what disease it is. And if you have suboptimal care, your disease will become more disabling. And if you're disabled, you're probably going to miss school and work. And if you're missing work, you're going to have a hard time maintaining a job or finding employment. And because optimal insurance in our country is so heavily linked to employment, it's hard to sustain optimal insurance that gets you access to specialty physicians. And so the suboptimal care leads to increased emergency department and hospitalizations and increased costs and increased morbidity and mortality. So the bottom line really is that the state of sickle cell disease care is that it's still primarily a lifetime of palliation, and that's an unacceptable fact. There's heavy burden for the individual living with the disease, for their family that's trying to support them, as well as society as a whole. How did we get here? So let's go back a little bit in US history, and let's go through awareness of sickle cell, acceptance, advocacy, therapeutic advances, and then where we are now, which is accelerated discovery. So when did we first become aware of sickle cell disease? Well, it started with Walter Clement Noel, born in Grenada in 1884. He gained acceptance into dental school in Chicago. And so he traveled by boat on the SS Sirens in September of 1904 from Grenada to New York City. And it's documented in hospital records in New York City that when he arrived after that 1-week voyage, he went directly to a hospital in New York City where he was found to have joint pain, shortness of breath, and skin ulcers. He then got better after a few days and continued by train to Chicago from New York. And he enrolled in the Chicago College of Dental Surgery. Several months later, in November, on Thanksgiving Day of 1904, his shortness of breath reoccurs, so he tries to manage at home. But after several weeks, the day after Christmas, he walks a few blocks to Presbyterian Hospital, where he had, again, severe joint pain and shortness of breath. And he meets an intern named Dr. Irons. And Dr. Irons takes a keen interest in this gentleman because he can't figure out what's wrong with him. Why is he having pain? But he looks at his cells under the microscope, and you can see on the bottom right that he sees these abnormal sickle-shaped cells. He talks to his attending physician, the senior physician, Dr. James Herrick, and talks to him about the patient. And Herrick is sort of mildly interested. And Dr. Irons follows Walter Clement Noel during his 4 years at the Chicago School of Dentistry and never establishes a firm diagnosis. And then Dr. Noel went back to the Caribbean, went to Barbados to practice dentistry, but died early at the age of 32. Interestingly, Dr. Herrick, the attending physician, published this observation of Dr. Noel in the 1910 Archives of Internal Medicine, but did not list Dr. Irons, the actual true clinician, on that publication at all. But this is the first awareness of sickle cell disease in the Western medical literature. A few decades later, Dr. Janet Watson, who is a pediatrician in New York City, made a critical advance in sickle cell disease because she observed that babies with sickle cell disease really didn't develop any sickled red blood cells or any symptoms until they were about 4.5 months of age. So she looked more closely at these babies' blood. And what she showed is that the development of sickled red blood cells actually correlated with the disappearance of the fetal hemoglobin and the production of adult hemoglobin. Remember, I told you hemoglobin has 2 forms. So once they made the adult form, they started having symptoms. So she surmised that it must be the adult form of hemoglobin that is making them sick. So this data suggested that red blood cells that maintain fetal hemoglobin may be protected from sickling. So remember this because this is important as we get to therapies. William Bosworth Castle was actually a famous Boston physician. I tried to see if he went to Boston Latin School, but I couldn't quite figure that out. But he may have. So he was at Boston City Hospital. He was a Harvard-trained hematologist. And in 1940, he did some experiments on sickle cell blood. And he showed that there was increased viscosity following exposure to low oxygen or hypoxic conditions. And then he did some other experiments, and he showed that when he looked under polarized light, that the sickled cells had this characteristic called birefringence. And really what that meant was that to him, it meant there might be something altered inside the red blood cells, an altered molecular alignment or orientation that was giving rise to the disease. But he had an issue he couldn't quite figure out beyond that, like what was going on. So Dr. Castle actually, several years later in 1945, was taking a train ride from Denver to Chicago, and he happened to be sitting next to Linus Pauling, the famous Dr. Linus Pauling from Caltech, Nobel laureate. He happened to be sitting next to him. And he wanted to, sort of pick his brain and say, I've been looking at this sickle cell blood. There's something different inside of it. Don't know what it is. Can you help me out? And there's actually, this is a quote of an interview that was done several years later. This is Dr. Linus Pauling speaking about this interaction with Dr. Castle on the train. And I will just pick out a little bit of it here. He said, Dr. Castle began to talk, telling the story about sickle cell anemia. I was only mildly interested because I thought the red cell is so complicated, it will be decades before anyone gets any significant understanding of it. And I wasn't listening very hard. I was being polite, of course, when he said that red cells do not sickle in arterial circulation, but they sickle if the partial pressure of oxygen is low. And immediately I said to him, I wonder if this couldn't be a disease of the hemoglobin molecule. So this was a really important journey across the country with these two gentlemen sitting next to each other. So now Linus Pauling was interested, but he had a problem. He was in Caltech, where he didn't really have a lot of individuals of African descent living. So he didn't have access to blood from individuals with sickle cell disease. So he wrote this letter in 1949 to his friend and colleague, Dr. George Birch, who was the chairman of medicine at the Tulane University in New Orleans, Louisiana, where there were a lot of individuals living with sickle cell disease. And in the interest of time, what I'll tell you is that he basically asked him, can you send me a little bit of blood from adults over there with sickle cell disease so I can do some experiments? I want to try to figure out what's causing this disease. So with that collaboration, later that same year in 1949, he and other colleagues from Caltech published this paper defining sickle cell disease as the first molecular disease. It was the first proof of a human disease caused by an abnormal protein, which you all now know is hemoglobin. The next decade actually highlights the British a little bit. They also played a significant role in our understanding of sickle cell disease. And it was Vernon Ingram and colleagues who sequenced the gene and showed the exact amino acid substitution that gave rise to this condition, that one little DNA sort of misspelling. So after this early recognition of like what causes the disease, we also, at least in this country in the 1960s, started to understand the clinical complications. And this is when the first studies on mortality in sickle cell disease were undertaken and published. There was effort towards early recognition and treatment of bacterial infections to try to reduce death in children under 5. And it was a widespread message that children with sickle cell disease had to be closely monitored for fever and seek medical attention immediately if they ever had a fever because of their susceptibility to death from infection. It was also during this time, then in the 1970s, where there was greater awareness and acceptance amongst the Black community. As you see on the left there, it was in the early 1970s that the former NAACP chairman, Julian Bond, introduced and passed his very first bill as a Georgia state legislator to establish a statewide testing program for sickle cell anemia. And on the right there, this is actually a picture from the Boston Black Panther Party, where they had a national screening initiative for all individuals of African ancestry to have community screenings to see who had sickle cell trait and who had sickle cell disease. But, you know, around this time, there was also stigma that was growing amongst those with sickle cell disease and sickle cell trait. And this is the cover of Jet magazine from 1958. And it's celebrating the fact that the very first Black stewardess for TWA was hired. It was supposed to be a celebratory edition of Jet. But if you look at the actual article on the inside, which there's a picture of on the right, what it's actually saying is that this first Black stewardess was actually subsequently fired because she was found to have sickle cell trait. And they were worried that having sickle cell trait blood and putting her high up in the sky would cause her to have some sort of illness or sickness, even though it's never been proven. So this is where I say civil rights starts to meet stigma in sickle cell disease and even sickle cell trait. Then our famous Nobel laureate Linus Pauling emerges again. This is 1968 in the New York Post. You're not going to believe what he was quoted as saying. Quote, "I agree we should keep these carriers," that is people with sickle cell trait, "from marrying one another. They should have tattooed on their foreheads symbols for the defective genes that they carry." So the person who was fundamentally responsible for defining sickle cell disease at a molecular level also became an advocate against individuals with sickle cell trait even procreating. So enhanced stigma began to foster enhanced silence. So it's no surprise to me that we don't tend to know very many famous people even now living with sickle cell disease, and that's because there's so much stigma associated with it. But there are two individuals who were very prominent around this time in history: Miles Davis, the famous jazz musician, and Paul Williams, front and center there as one of the original Temptations. Both had sickle cell disease, but lived with it quietly and were not known to be advocates in any way, and lived sort of, without public awareness about their condition. But because individuals with the disease weren't empowered really because of stigma to try to advocate for sickle cell, it really began to be on the shoulders of physicians to do the job for them. And there was no greater giant than Roland Scott, who was the head of the Howard University Center for Sickle Cell Disease, who in the 1970s published influential critiques on the status at the time of research or lack thereof, and clinical care or lack thereof for sickle cell. And he campaigned with others for increased funding for research as well as healthcare services. And this tireless work led to then President Richard Nixon signing the Sickle Cell Anemia Control Act in 1972, which finally allowed for federal funding to enhance clinical care as well as research. And this action and advocacy in the 1970s contributed significantly to improvements in sickle cell disease care, particularly amongst children, that was realized in the 1980s and 1990s. But stigma surrounding sickle cell trait, again, not a disease, just a carrier state, was revisited in the 2000s in two ways. So in the bottom left, you see a typical NCAA athlete, football athlete. What happened in the 2000s is that there became a mandate for every Division I NCAA athlete to be screened for sickle cell trait because of concerns about sudden death associated with extreme physical exertion, which has never been substantiated actually scientifically. And this was an issue for these young athletes who felt that if they were found to have sickle cell trait, it may limit their playing time and also limit their chances to be recruited at a higher level. And on the right there, you see the opioid crisis that many of us know about. We live in it now. Unfortunately, individuals with sickle cell disease have gotten caught in the crossfire of the opioid crisis. They legitimately need these pain medications to treat their severe pain, because of the opioid crisis, which has nothing to do with sickle cell patients, it's made it harder and harder for them to get access to the meds. So I'm going to try to speed up here. I see the time. But we have unique challenges in the US. I think living through this pandemic and living through the time of George Floyd, and others has really driven to the forefront that we live in a disjointed healthcare system. There's systemic racism, and luckily we're all getting more comfortable, I hope, in talking about it and working together to combat it. We've also seen that there's disparity in COVID mortality rates associated with being Black in America, and disparate access to vaccination amongst those who are Black and brown in our country. And the effect of racism was really put to the forefront in the medical community this past year when some of my colleagues at the Cincinnati Children's Medical Center published in the New England Journal of Medicine the effects of systemic racism on sickle cell disease care. There have been a lot of recent advances in sickle cell disease. I told you 3 new FDA-approved drugs in the last 3 or 4 years. We have, like you see on the left there, disease-modifying therapies, meaning treatments that can kind of sort of ameliorate and lessen sort of the symptoms that people experience, decrease the number of pain episodes they have. But also on the right there, we have curative intent options, which are heavily rooted in making bone marrow transplants safer and more accessible, and excitingly, introducing the idea of gene therapy to try to cure the disease. So what is gene therapy? So it's really complicated to explain, so I'm going to do my best. But looking at our picture of DNA again, where we see how an individual, like on the bottom there, inherits just a very small misspelling in their hemoglobin DNA. What gene therapy does is it either inserts a properly spelled word into the person's DNA, or it edits the misspelled word to make it be spelled properly. And so how do you perform gene therapy? Well, first of all, like I said, it's potentially curative. It does not require any donor. You don't have to have any other individual involved in this process. What you do is you take the patient, the person with sickle cell disease's own bone marrow, you take it out, you put it in a Petri dish, and you do your magic gene therapy to either correct the misspelling or add in a new gene that's spelled correctly. This is called either gene addition or gene editing. And there are other ways to do this, but I'm trying to be as simplified as possible in my description. Once you've done the gene editing or gene addition in the person's bone marrow in the dish, you're ready to give those corrected cells back to the patient. But you can't simply do that. You have to wipe out the patient's existing bone marrow, okay? You have to make room in the bone marrow. So what you have to do is give them high doses of chemotherapy through their veins to completely wipe out their bone marrow. So their bone marrow is empty, and they're able to then accept the modified gene therapy manipulated cells back into their body, where they go into the bone marrow and they grow and they propagate, and the person then has their new healthy red blood cells. So we're in clinical trials right now in sickle cell disease and gene therapy using several different strategies. But the issues right now are, how safe is it to give somebody high doses of chemotherapy? Can you cause other complications, secondary complications, including leukemia? Are there other toxicities that we don't yet know about? And one thing to keep in mind is that most of these regimens, these chemotherapy regimens that are the backbone of gene therapy, actually make the person infertile. And as I told you, most individuals with sickle cell disease are under the age of 40. So almost by definition, you have individuals of childbearing potential who you're offering a treatment that's going to make them infertile. And that makes it very hard for an individual with the disease to make a decision to go through with that treatment. But it's an exciting time because of all the different gene therapy clinical trials that we have across the country. The early results, which are in the next couple of slides that I won't get into in the interest of time, are very encouraging. But I really want to make sure I've hit home that these advances in research that we're seeing are really outpacing where we are with care delivery. And that's due, again, to transition, to increased adult mortality, unnecessary mortality, largely rooted in abysmal access to care across our nation. And the potential repercussions are that these clinical trials, including fantastic gene therapy trials, may not be able to be completed, because if you don't have patients that are in routine medical care, they don't have the knowledge or access or the trust with a healthcare provider to talk about enrolling in one of these clinical trials. And then if you look into the future, say any of these new treatments under clinical trial investigation now are approved, well, who's going to write the prescription? Who's going to refer a patient for gene therapy, for example, if there aren't adult hematologists like myself who are out there available, ready and willing to see these patients? So in conclusion, I hope you will appreciate that the approach to someone living with sickle cell disease requires an appreciation for both the physical as well as the societal challenge that these individuals face. I hope you'll appreciate that this is a long neglected disease, particularly in our country, but it's now finally getting the focus it deserves, and that we need enhanced advocacy and awareness to try to move this disease forward. We need to support scientific discovery, develop new treatments, including gene therapy, and this will all lead us toward progress and reverse of longstanding suffering. Just want to end I wish that this picture was actually in reverse so you can see Mr. Akeson's face, but not mine. But Mr. Akeson played such a critical role in my love for science, biology, medicine. I was privileged to have him twice at BLS, both in 9th grade biology and again in AP biology. And if you're out there, Mr. Akeson, watching, and I think you are because you sent me a wonderful note, I just want to publicly thank you for all that you did, not only for people like me, but others, my classmates. You were so influential. And I just want to thank you in front of everybody. So thank you to BLS and the BLSA. And again, to all of my class of 92 colleagues that may be watching.
Right. Dr. Andemariam, you've got to let us know before you do that so we can have our Kleenex ready in time. That was such a wonderful comment. I didn't have the privilege of having Mr. Akeson, but clearly I should have, because I too might be in position for a full professorship. So congratulations first and foremost on that. And thank you for just taking us to school on all things sickle cell and gene therapy. I have a couple of comments, but let me just remind folks, we do have about 4 minutes left. So we do have time for probably 1 or 2 questions. We'll wrap with some remarks, but I'm going to tell you, Dr. Andemariam, you literally knocked out every question that we received before this presentation. So that's how fantastic and brilliant you are. So while we wait for a couple of questions that come in, let me confirm a couple of things. We had our fact checkers fast at work here at the BLSA, and we could confirm that Dr. William Castle did not graduate from Boston Latin School. We can't all be perfect, and that's okay. He did good things. I will tell you, these are probably the most notes that I've taken in one of these webinar formats. You know, they say that people remember stories, not really facts. You flipped it on its head. You've given us stories, facts, you dropped history, and I'm ready to start schooling my family and friends on all things sickle cell. So thank you. And thank you for the very important work that you do in this space. It is not easy. You have to have a passion for it. And many are appreciative of it. So looks like we do have a couple of questions that we've lined up. So let me hit those first, and then we'll go from there. So this has been amazing. Thank you, Dr. Andemariam. Are women and men impacted the same with regard to sickle cell disease?
Yes, I'm sorry I didn't review that. So the inheritance is equal. So men and women have equal opportunity to inherit sickle cell disease. But I will say, and maybe I'm biased because I'm a woman, sorry, Nicole will back me up here, but in my observation, my women living with sickle cell disease, I think, struggle a little bit more. I think that they struggle trying to not only care for themselves, but are oftentimes the primary caretakers at home. So I have plenty of young women with sickle cell disease who are in extreme pain at home, but won't come in for treatment because they don't have anyone to take care of their children. So I think the burden is somewhat higher. Also pregnancy. Pregnancy is risky in sickle cell disease. And so I think that they struggle oftentimes during pregnancy and shortly thereafter with exacerbations of their disease. And this is something that men with sickle cell disease don't have to face because they don't carry babies. So I think the burden is a bit higher for women, but they're equally likely to inherit sickle cell disease.
Great, thank you. Our next question, what are some efforts that schools can do to increase interest in the field of hematology in young people? And I'm going to say, shout out to our BLS students who are watching. We need some future Dr. Andemariams. So what are some things that our schools can be doing to increase knowledge around this?
Well, I think, I'm not sure. So for BLS, for example, I'm not sure if there's hematology in the curriculum, but I think simple tasks like taking students to the microscope, looking at blood cells under the microscope. I think explaining how complicated blood is. I think we think the blood is just there. In fact, my cardiology friends say that the heart does all the work. It's pumping the blood around, and I say no. The blood, the heart wouldn't even exist if it weren't for the red blood cells supplying oxygen to it. So I think taking kids to the microscope, teaching them about the human body, biology at its finest, I think could help sort of create awareness and interest in not only hematology, but all of medicine. We simply don't have enough doctors in this country to meet all the needs. We have a lot of doctors that we get from other countries to take care of our American population. So I think medicine is an exciting field. I never regretted the choice, even though it was a really long road. I feel good about what I do every day. Last year really highlighted that. Like, people in healthcare are like super important, right? So important that we just put them out there into a pandemic and said, go for it, and we rise to the challenge. We do it. We put our lives on the line. We put our family's health and safety and well-being on the line, but we do it because I think because on a daily basis, I think we feel like we're making a difference.
Indeed, thank you. We are just a minute past 1, so if you'll indulge maybe one more question, I'll wrap with some responses, but there are 2 other questions, and if it's okay, I'd love to send them to you and we can get the responses back to these individuals. Okay, great. So let me pick one. What are your 3 suggestions for reversing this vicious cycle, if that's something that could be answered?
Yeah, three what you said?
3 suggestions for reversing this vicious cycle.
I think we need all hands on deck. So the first thing is, whether you are affected by sickle cell disease directly or indirectly, become an advocate. Become an advocate for enhancing sickle cell disease care and research and treatment. I think beyond that, be an advocate for combating systemic racism in healthcare. It's an issue. It's an issue, and it's not just in sickle cell disease, it's in all of medicine. So those are the 2 things I can think about. The other thing is, it's a little less related, but when I think about the statistics associated with sickle cell trait and sickle cell disease, I bet you it's very likely that we have had classmates at BLS who had sickle cell disease, and we just didn't know it. We just didn't know it. And I think creating an environment where people feel comfortable, no matter what their condition is, to feel free to express it, whether they live with cancer or a cancer survivor, or have diabetes and are trying to struggle through school, trying to inject insulin quietly in the nurse's, room, so the other students don't know. Creating an environment where having a medical condition doesn't really make you, different, just makes you special in a different kind of way.
Indeed. Thank you. Again, we could go another hour with this, and we'd really love to, but we want to be mindful of your time. You've got things that you need to do, and we want to make sure we're mindful of our audience's time as well. So again, Dr. Andemariam, thank you so much for all the work that you and your colleagues are doing. You've got new advocate here, and I'm sure many of us, if not all of us on this call, will go out and wave the flag in the fight against sickle cell disease. So a couple of things before we close. As I mentioned, this webinar has been recorded, and you will receive a replay of this recording along with the survey early next week at the latest. So, let us know how we've done, and, we welcome your feedback on this webinar in particular. I'd like to take a moment to invite you to the fourth and final in this slate of Inquiry and Insights webinars. We will visit with Dr. Joseph Nevins on Tuesday, June 22nd, and he'll navigate us through the complicated and sometimes ugly history that is our beloved and cherished city of Boston, Massachusetts. So you'll see information inviting you to attend that as well. And again, thank you for your participation today. On behalf of the Boston Latin School and the association, we thank you for your support through which this webinar series was made possible. We wish you and your families continued good health and wellness. Thank you and have a great afternoon, everyone.